You can hear me okay? I tend to move around quite a bit when I speak, so I hope that's all right. So today we're going to talk a little bit about a patient-centric approach to incorporating a hypoglossal nerve stimulator, upper airway stimulation, or Inspire into your patient's treatment plan if necessary. And let's see, this one here. Let's just go on here. My disclosures, I am a senior lead clinical for Inspire. It's actually my retirement gig. I was in clinical practice for 38 years. And I still do on-hands patient care day in and day out with all spectrums of sleep apnea, from treatment, diagnosis, respiratory therapy. I work with, as the executive board for the AAPMD, American Academy of Physiological Dentistry and Medicine. I'm the new director for the foundation, the International Foundation for Airway Health, and I'm an editorial staff writer for Dental Sleep Practice magazine. Right now, the newest exciting adventure that I'm dealing with is with the Endeavor. So early intervention by way of facial growth guidance and breathing disorders for children 0 to 72 months. So my deal, my bailiwick, is figuring out who is this person that we're treating. Because they're at the center of each and everything that we do, no matter what part of medicine or dentistry that we belong to. The person is always first and foremost important. So if we look at the person here, is this our little pointer thing? How does this thing here work? Whoop, what did I do? Whoop, okay, not that. Okay, so up in the corner here on the left, I guess, since I don't know how to use the pointer, patients at the center, all of the care providers are around them. They interact with each other and the patient. So collaboration is probably the most important piece of this. If we can't collaborate as specific members of the medical community to serve the patient's best interest, then we have a problem. And one of the things we have to understand is, who is this person? Because a formerly very healthy individual who now gets handed a diagnosis of obstructive sleep apnea has very different viewpoint of who and what they now are. Their sense of self changes. They perceive themselves as being invincible today, and tomorrow you tell them they now have a lifelong chronic disease they can die from. That's pretty scary. And it's enough to throw your game way off. So I start, when I see patients, doesn't matter who I get them from or how they've crashed and burned elsewhere. Lots of times when I was in the dental sleep medicine practice, my door was the last one in the hall. That's for a reason. Because if you can't get by me, there's nowhere else to go. I'm usually the person I'm the fixer. Bring me, you're tired, you're cranky, you're unhappy, you're really pissed off. And drop them on my door, and I'll figure it out. Because that's what I do. There's no judgment involved, ever. 6 appointments it might take before I find out how somebody self-medicates. So you have a couple of beers, maybe you have 5 or 6 glasses of wine, maybe a couple of hits off a bong on Saturday. How am I going to know how that affects your sleep until I get to know you? Okay? Do I care? No. I'd prefer you didn't shoot up heroin, but if you do, we'll deal with it. So it's a little bit different. It's a little bit different. I believe in binary questions. Simple, easy. Are you satisfied with your sleep? That's a yes and no, friends. Either you are or you aren't. And if you're not, let's find out why. There's something to be said about obstructive sleep apnea, sleep and breathing disorders and everything. There is no such thing as stasis. Okay? I am a chaostician at heart. Give me chaos, I'll figure it out. So think about it. PSG, HST, cardiopulmonary coupling, HRPO, any kind of home monitoring, any kind of wearable. It's going to tell you something each and every day. So what I did for you today worked great on that PSG last night, right? But tomorrow, maybe it's twice as bad. Because your body's not the same on any given day. So when you deal with chronic disease, diabetes, thyroid, any of those things, your numbers are going to change every single day. Your body is going to change every single day. Sadly, I have had to come to terms with the fact that I am older, 1 day older, every single day. Not crazy about it, but I've come to terms with it. So we really need to understand there's nothing static about what we do here. I believe that when we get a lot of these patients into our practices, they've been scarily diagnosed. They've had a video call with the doctor. They've had a sleep test ordered over the video. They've taken their sleep test. They've had their video conference after their sleep test. They've been mailed their CPAP machines with no instructions and nobody to help them, and they're mad. And a lot of patients get to us and they feel like this obstructive sleep apnea thing is nothing but a money grab. It's a money grab, and they don't like it. And why doesn't my insurance pay for this and that and the next thing? So they come to us with what I call the suffering of ignorance. They have anxiety. They're skeptical, big time. They're resistant. Now, in a 2015 dissertation that was done by a brilliant student back at Princeton, Dana studied and found out that the most contested diagnosis on the planet is obstructive sleep apnea. People would rather you told them they had cancer. Pretty scary. And resentment. They resent that their life is now changed. It's going to be different. Now they can choose, based on the level of their sleep apnea, to treat or not. We're going to talk about that when we talk about risk. But the bottom line is this is this person that now is the center of the universe that you are deciding to orbit around. Decide if you can help them with whatever you do. 2010, read a great article by my good friend Dave McCarty. This is a must-read, only because if you understand Occam's razor, it's great in a lot of things, not everything. But I use the 5-fingered approach to treat each and every of my sleep patients. So, what is it about the 5-fingered approach? Using the thumb first, circadian misalignment. Let's talk about what is their life like? How do they sleep? When do they sleep? Do they have sleep-wake issues? What are the problems with their sleep? Are they impacted by their work situation? So do they have some sort of a circadian issue? That's important. Pharmacological factors. Half the people I see haven't had a medication reconciliation in donkey years. Honest to God. Anybody sat down and told you that 5 of the medications that you take cause sleep fragmentation? Anybody told you that? Okay, you take something for your thyroid, sleep fragmentation is caused first and foremost by most of the antihypertensives, by all statins. Okay, how many of the patients come in, they're taking a statin? It makes their restless legs worse, and they can't understand why they can't sleep. So you have to do complete medication reconciliation so you can really understand how they take, what they take, why they take it, and when they take it. Okay? Easiest thing about the statins is it's the old statins that used to be you had to take them at night. Oh, they're not going to work if you don't take it at night. That has changed with all the new statins that are on the market. Not necessary at all. Your body does not know, as long as you take that sucker one at a time every 24 hours, it doesn't know what time you took it, as long as you took it. So, you tend to have restless leg or you have cramps from your statin, guess what? Simple as you can do. Instead of taking it at night, which is not necessary, you take it at lunchtime or breakfast and you walk off the side effects. Ta-da! One less thing to fragment your sleep. But nobody looked, nobody asked. Okay? Medical factors, disease processes. We have to look at what else is going on with this person. Is their daytime tiredness and fatigue only based on a sequelae of obstructive sleep apnea events, or is it part of their sequelae of their AFib, their cardiac medications? Okay, you have AFib, you take cardiac medications, guess what, friends? You're tired all day. Nobody cares if you slept 10 hours. You're tired. So we have to look at what are their disease processes. Are they diabetic? Do they have thyroid? Hashimoto's chronic fatigue goes along with that. So along with their other medical factors, I personally think psychiatric and psychosocial factors should go up by the thumb. It's the biggest piece of this as far as I'm concerned from where I sit in my clinical practice. And when the thousands of patients I've treated over the years. Let's remember, there is a person attached to this disorder. There's a person back there. And they're affected by their environment, by their family life, by their job, by one thing that nobody ever mentions, how about grief? You want to talk about somebody crashing and burning no matter what therapy? They were doing great on their sleep appliance, they were doing great on their CPAP, great on their HNS. And they come in and they have just hit the skids. And you're like, damn, what happened here? What happened here? Guess what? It's called grief. Doesn't mean somebody died. Okay? But something in their life has significantly upended their assumptions about the world and themselves. And that is tough to deal with. So we have to recognize that you don't need to tweak that appliance. You need to listen to them. You need to talk to them. Then you need to find out how you can help best intervene in a way that is meaningful for them so that they can accept it. And then give it some time, and if you still need to tweak the device or whatever, you do it. But let's not forget that that's a big piece of it. Depression, anxiety, all of those things are part of the psychosocial part of it. COVID, my God, that's enough to put anybody over the edge. And if you've suffered with COVID or you've had a family member who suffered and died from it, that's pretty scary because we're still living with it. So it's something there. And then last but not least, as far as I'm concerned, your primary sleep diagnosis. Yes, so what? Is it obstructive? How bad is it? Okay. What component of it is obstructive versus central versus whatever? We don't even score central hypopneas anymore. We don't even score those things. They're benign. So what? We have to remember that the Sleep Heart Health Study and the Framingham study, these are great studies that tell us about risk of dying and all of these things. And I'll talk about that in a minute. But they don't score some of the stuff that they used to score in the old days. They just lump it all in with obstruction and off you go. So the cure for suffering and ignorance, as far as I'm concerned, is understanding the 5 reasons why you're going to treat. Why are you going to do this? Develop a strategy. Okay, so here is this person. This is what they can and can't do. I firmly believe you tell them to sit in front of you, dump the detritus of their life on the floor, out of their bucket, in front of you. Let's sift out what they can, will, and won't do. This is absolutely, MMA, absolutely no. Okay. CPAP, absolutely no. Well, if you want this other thing, you got to do that. What is something I could tolerate? And is there a means by which the strategy can change? If not plan A, plan B, or maybe plan C. Because guess what? Over a period of 20 years with some of my patients, I've gone from plan A to plan D based on how they've changed, how their bodies have changed, what their health status has changed. So sometimes plan A worked for a while, but it no longer works anymore. That's why one antihypertensive doesn't do it if you don't change a lot of other things, because the brain checks out. Okay, so you have 2 antihypertensives in order to get you back into the normal range. Okay, so now we've got quote unquote high set point hypertension. You will never go back. You're stuck there. So that person is never going to be that same person when they started with one antihypertensive. Okay? What are the complications that could lie ahead for what you're deciding to do with that person? What are they? And whether we'd like it or not, because there are all these other people in the room that this person may talk to, lots of other doctors, specialties, their primary care doctor, whoever, who may think that whatever you do is BS. Okay? And there is that, let's be honest. Okay? How do we deal with differential diagnosis? With another doctor saying that, well, I don't necessarily think that what that person's telling you to do is the right thing. It's a real thing. And for dentists who have been sidelined and maligned by the medical community for too long in this adventure, You are the folks that are spending a minimum of 45 minutes to an hour with each and every one of these folks every time they opens their yap to get their teeth cleaned. Perfectly placed people to screen and get people segued towards proper diagnosis and on the right path towards and developing a strategy for their possible problems. So we're going to talk about why should we treat? So they get a test, it comes back. So why should I treat? What do I care? It's pretty difficult to decide at what is a risk factor for you for mortality and morbidity, because basically we're talking about not dying here. Okay? Untreated sleep apnea, Framingham study, heart health study, mortality rates go up significantly if and only if the patient has greater than an AHI of 30 with the 4% rule. That's when mortality and morbidity skyrocketed on those studies. Now, if your AHI was between 5 and 15 in both the Framingham study and the heart health study, the risk of mortality and morbidity was actually like very low, less than 5%. It stayed up in the 90s. You're going to live more than 20 years if you chose not to treat. One complication with both of those studies is it didn't factor in two things. Two things that are important. Central sleep apneas were not factored in, nor was altitude. And altitude is a real killer when it comes to treating sleep apnea using any therapy modality. So one of the reasons, of course, we treat risk. Second reason is snoring. Okay, you guys have heard a ton about snoring, about the physiological and tissue damage caused by snoring. Chronically swollen tissues, chronic sore throat, chronically stuffy noses, mouth breathing, dental decay, periodontal disease, all of those things, as well as the fact that snoring, by virtue of vibrational trauma, racks up your carotid arteries and predisposes you to a TIA. Okay? The strokes that you get from sleep apnea are not caused from your blood pressure per se. It's from the fact that your carotid arteries now have all this crap clogged in them from vibration, and they're stiffened. So the blood doesn't flow properly. So that's really important, is understanding, of course, it's a reason to treat. Then we have the psychosocial part of the snoring. It's embarrassing. Okay, snoring is right up there with incontinence. It's right up there. People won't want to admit it. They don't want to be told they have it, and it's socially stigmatizing. So, of course, it's a reason to treat. You don't want to give up living your life, your camping trips with your family and friends, and being intimate because you're afraid that you're going to start snoring. You're changing your life. This is changing how you live your life. It's a reason to treat. Okay? Sleep. If we don't get good, deep, restorative sleep, our brain doesn't heal. We don't process emotional memory. We don't, your vitamin D levels and your epithelial cell walls get trashed. We need deep restorative sleep to rest and digest so that we don't end up with aerosolized, every time you have a sleep event, aerosolized gut juices going up into your esophagus and into your upper airway and exacerbating your GERD, making that sore throat worse, making you feel like you have a globus sensation. You got something stuck in your throat constantly. That is, by nature, aerosolized gut juices coming up and racking your tissues. So we really want to make sure that sleep is deep and not fragmented. We really need to make sure that the quality and the quantity of sleep is appropriate for brain healing. We know that if you don't get enough sleep, quality and quantity, amyloid proteins build up in your brain that predisposes you to amyloidosis, which is what? Alzheimer's and Lewy body dementia. Thank you, but no. I'll pass. Wake symptoms. Okay? Foggy brain, attention deficit, executive function is just not what it was. Forget your car keys, like all the time, not just once in a while. Crankiness, moodiness, inability to hold a conversation, inappropriate, falling asleep at the wheel or in a conversation or in the movies. So the wake sleep complaints are really important. So when I say, are you satisfied with your sleep? I could also say, yes, no, are you satisfied with how you function during the day? That's a huge question. And what have you stopped doing that you used to really enjoy? Because for me to get a patient to do well in therapy, that's the carrot and the stick. I want them to get back to something they miss. That's a goal. And it's worthy of taking the time to find out what that goal is for that person. That's the carrot. Is what do you really want to do again that you can't do anymore? You've stopped doing because you're just too tired. And comorbidities. So heart disease, stroke, diabetes. I would venture to say, and in the early days when I first started talking about things like vitamin D and sleep, people looked at me like I threw up on their shoes. Now everybody's talking about vitamin D. Okay, I've been doing it 20 years. Yee-hee. Why? Sasha Gomanik's one of my best friends, and she's been researching vitamin D for 20 years. I've just been lucky. But the other comorbidities that are really important here is you have to think about the pyramid of life. So if we look at a pyramid, like the food pyramid, right? We look at the pyramid, and life, health, vitality, wellness is at the bottom, right? And at the very apices is where you kick the bucket and you give up your space on the perch. When we look at disease, 20 years ago, you had high blood pressure, little heart disease, maybe a small stroke. And then you had the big one. You had a heart attack. They finally gave you a sleep study. I would venture to say that sleep and breathing disorders don't belong halfway up that pyramid. They are foundational disorders. So your heart disease is worse, your blood pressure is bad, your thyroid and your diabetes, your sugar levels, your autonomic dysfunction, dysregulation is all bad based on the sleep and breathing disorders first. At the bottom as a foundational disease, and everything builds on top of it until you die. A little different thinking, but it's worth thinking about. So is heart attack, stroke, thyroid, and diabetes, are those foundational diseases, or are they sequelae of sleep and breathing disorders? Which means we need to intervene sooner and quicker and earlier, in other words, even in little kids, to make sure that we're staving off long-term health disease. So a lot of different people in this room, a lot of different backgrounds. Every one of you has a tool, but your tool is just one tool in this box. My challenge to each and every one of you is to, if you don't have more than a few tools, find people who have the ones you don't have and make them listen to you. Encourage them to partner with you, to keep the patients in the center of the spectrum to work on so that you can collaborate, and with all of the tools put together, you have a better chance at helping these folks. So it's really important we realize that patients that are successful today, again, because of time, can become failures. You don't give somebody an appliance, you don't just do an MMA, you don't do nasal surgery, you don't do hypoglossal, you don't do any of these things and say, go with God. It's a long-term relationship for each and every one of these patients, and we have an obligate responsibility to make sure that what we've done today is kept up and followed up and possibly changed tomorrow in order to serve the patients in their best interest. So a couple pictures you've already seen. Why do we have this epidemic going? It's getting worse than ever. Our faces are shrinking by generation. Beautiful Neanderthal faces with 32 teeth in their heads that were straight, they weren't crowded, had big, beautiful nasal complexes. All of their teeth, again, wide, beautiful growth, now look like this. Tiny little nasal capsules, vaulted palates, trapped mandibles, all of this stuff. Steep angle on the bites. All of this stuff is time. It's environment, it's change, it's industrialization, bad diet, and the lack of nasal breathing, and long-term breastfeeding people don't do it for 2 years anymore. The American Pediatric Association just came out this last week and said women should breastfeed for a minimum of 2 years. So you've also seen pictures of the faces today. Black line is the Bolton norm, been around forever. I use this, we do it for children, especially when we're looking at facial growth. Now, I would argue that this is the same patient before and after 4 bicuspid extractions and retraction orthodontics. What have we done to help that person? Nothing. So we straightened their teeth. Okay. We now have a vaulted palate on the left before that the tongue kind of sort of fit in, still a little snug, vaulted palate, not really good. Then we take out almost 10 millimeters of tongue space. We pull the teeth back so that this kid has straight teeth. And guess where the tongue goes? Into the garage. The tongue that used to sit kind of sort of in that bigger box is now crammed and pushed back in the little box. So industrialization and orthodontics have done a lot of good things, but what they haven't done for a lot of people, and you can argue, oh, it doesn't change the velopharynx at the back, it doesn't change the airway measurements. That's fine if you cherry pick the data. But anecdotally, if we look at people, we know that thin-fit females who've had four bicuspids removed end up with TMD, upper airway resistance, snoring, pain pattern syndromes, all of that stuff. I get it day in and day out. And a lot of them, we reopen those extraction spaces and all the symptoms go away. So this is from 2021. Scary as all get out, but the toughest sleep apnea patients you will treat morphologically are your Asian patients. And guess where they're taking out the most teeth? Good luck. I have in the Bay Area, we have the highest proportion of hypoglossal nerve stimulator patients that are of Asian descent, and we find that they are the toughest to treat. And they have had the toughest time with oral appliances and the toughest time with CPAP. So moving along towards upper airway stimulation. So right now, these are the surgeries that are pretty much available in combination and in staging for sleep apnea. In the old days, tracheotomy was first and foremost. Surprisingly enough, I actually have a patient that we just have done a study on. We did after they'd been trached, this is a person who'd had an MMA, this is before Inspire. MMA had all stage surgery for the nasal, the whole 9 yards. Ended up with a trach, and guess what? Still collapsed. Why? Because the collapse was below the trach. Not everybody can be fixed. Okay? A lot of the adenoidectomies, UPPP can be done in a number of ways. A couple of them I'll talk about a little bit later, but these are what is available currently right now. Hypoglossal nerve stimulator has been approved by the FDA in 2014, but there was over 10 years of research and development before that. So for instance, it has a 10 to 11 year battery. I'm changing out right now some of those batteries from the STAR trial patients. And those things have worked. They have been workhorses, those batteries. And it's a very simple 30-minute procedure to change out a battery, just like you change out a pacemaker. We have 260 peer-reviewed publications. As of last week, I checked on PubMed. Help yourself. STAR trial is published. The ADHERE registry is published. There is clear transparency about what is great and what isn't about it. And it's, the indications are as 18 and older right now. The AHI has to be greater than 15 or less than 65 for most commercial insurances. The veterans, Kaiser, and Medicare, often the patient's apnea can be well over 65, and they don't have a problem with paying for it, especially patients who have had everything in the kitchen sink already done. So less than 25% of mixed and complex central sleep apnea. So on their sleep study, which needs to be a pure diagnostic study for qualification for hypoglossal, it has to show that they have less than 25% central and mixed apneas. Now, are they central hypopneas or central obstructions? We don't know, because they don't score them. Everything gets lumped into obstructives at this point. Okay? Their airway, when put under anesthesia, propofol anesthesia, must indicate that they do not have concentric collapse. Okay? So the indications are they have AP collapse, some lateral collapse, but they cannot have concentric collapse. And then they have to have tried and failed CPAP. So what does that mean exactly, tried and failed CPAP? Put it on during the study and said, no, I'm not doing that, get it away from me? No. There is not a specific timeline. But I also am a true believer that CPAP out of a box with no instruction is pretty well guaranteed to fail. Is it been initiated properly by somebody who understands how to initiate CPAP so that the patient can at least give it the old college try? I prefer that they at least do the college try because this is a surgical implant. Just like having an MMA, it's at the end of the road. Okay? You don't want it, this is not frontline care. We want to make sure that something that is benign goes first. And oral appliance. Contraindications is not for the kiddos. Okay? So little guys, we want to make sure that we take out the tonsils and the adenoids as is appropriate. We also expand the heck out of them, as big as we can get them. And that means expanding in the AP as well as lateral. And that we try and manage this horrific epidemic of obesity in our kids. So it is not for morbidly obese folks. Not for anybody who is pregnant or could become pregnant. We have some very severe sleep apnea young women, but if you're in your early 30s and you haven't had your children yet, this is a no-go. We want you to wait until you've had your children. So again, anybody with a preponderance of central and mixed apnea is not a candidate. Anybody with organic brain disease, okay, what exactly does that mean? There are certain Lou Gehrig's disease, things like that. Now, have we had patients who have hypoglossal, who have developed amyloidosis, who have developed Lewy bodies dementia and or Parkinson's? Yeah, of course. Does that mean we rip the thing out and they stop using it? No. But they may at some time need to make sure that there's a care provider that is able to help them turn it off and on. Simple as that. My baby is our clinical trial for the children with Downs. So we have over 260 children that have gone through the clinical trial, many of which were trached their entire lives to sleep, who now are breathing with Inspire, without trachs, and swimming for the first time in their lives. The cognitive improvements alone in these kids is stifling. You would not believe how much better they are. So we're still on our way. We still have a ways to get through trials, but at some point, we believe that the Downs and Marfans are going to be our first group of children that are in the 12-year-old and up range. So, pushback. Okay, I see all these ads, and it's misleading. And I don't like, doctors say, oh, I don't want it, I don't believe in sleep surgery. I see all these ads, and patients come in, and they want this thing and they don't get it. Sure, they want this thing and they don't get it. But the bottom line is that you can't turn on TV anywhere and not see an ad for something that's going to either cure your falling arches, your baldness, your A1C, or your obesity on TV. Ask your doctor. The ads for this are no more than ask your doctor, because a prudent physician, a prudent provider, is going to say this drug for A1C is not appropriate for your particular condition. Caveat emptor. Just because it's on TV does not mean that it's the right thing for you. So good, prudent practitioners and dentists who might be referring into it. I have tons of dentists that have these materials in their offices. And they say, you can ask your doctor about this if you've failed, all of these other things. Great. But it may not be right for you. So there's a criterion. So the journey begins with a comprehensive sleep assessment, a sleep study, which is a diagnostic all night with no treatment, no CPAP, no oral appliance, and a really firm medical and psychological history. Okay, it's really important. Now, for most implant devices in this country, any kind of neurostimulator or brain stimulator, most of those require a psych eval before you're putting a stimulator in somebody's body. Inspire is one of the few that does not. However, providers know if a patient isn't in a position where they're going to psychologically adjust to this well, they need to be looking at that. And people, for instance, we need to really look at things like chronic insomnia that's not treated. If this neurostimulator is going to be going off all night long and you don't sleep at all, we have to deal with your comorbidity of the insomnia and treat that first. Get that under control before you would be a candidate, and that's just good practice. Who puts this in? EMTs and OMFSs. The only patients that the OMFSs cannot treat right now are Medicare patients because CMS, in their divine wisdom, and for no rationale whatsoever, decided that they only wanted ENTs to perform this procedure. This is a drug-induced sleep endoscopy. The patient is given propofol, Michael Jackson drug. We all know how well it worked for him, but we don't do it that way. It's a very small dose, incrementally, that's given so that we can look at how the airway actually collapses while the patient is mimicked in sleep. So an airway that collapses from the front and the back, AP, at the velopharynx, is considered a good patient and a good candidate. Now this is concentric collapse. Think camera shutter. So if the airway collapses like a camera shutter, think about how much energy it's going to take to blow that airway open. Unlike CPAP, upper airway stimulation is not a rescue therapy. It's interventional. It's going to fire and stop the collapse from ever happening. It's a totally different kind of therapy. It's going to prevent the collapse. So then if you don't have a collapse, you don't have catecholamines and the fight or flight hormones dumped every time there's an event into the system that now the body and the brain have to decide, oh my God, I have to diurese all this stuff out. And you have people up 82 times at night to pee. Doesn't work that way. This is interventional. So this is a film that's going to show a little bit longer film of the airway. The scope is a little bit low on this one, I would hazard. However, you can see that the lateral walls on the side, these two pieces of tissue there, they're stable. And that's what matters. It's not collapsed. There you see that that's the back of the uvula, and that's the snoring. And what we're looking for is, does this stay stable across the velopharynx and collapse from front to back? That's what we're looking for. And if it does not, then they're not a good candidate for it to begin with. But if we move on, my folks that I've been working with the Stanford people now since 1994, and 3 of my very good colleagues, we decided that could we change the way UPPP was performed in order to turn a concentric patient into an AP patient? Could we do it? And the answer is yes. So by curtaining the tissue on the lateral walls, instead of it scarring up, it's going to scar to the side, and 3 months later, when you do that same DICE, the patient no longer collapses concentrically, they collapse AP. And so a patient who has already had everything else and still really wants this therapy, because again, this would be considered another form of staged therapy. So think of the person attached here. They've already gone through a bunch of stuff to get to this point, and then they can't get it because it's concentric. Now they have to go through another step. But if they're a patient who really wants this, this is what they're going to do. So these films are going to show you what the airway looks like without stimulation. You can see this is the tongue base on the left. The taste buds are there. That's breathing through a cocktail straw. Imagine supporting a 200-pound body breathing through one of those cocktail straws. Okay, and this is what it looks like with the gentle stimulation. Here's the tongue base holding open. And then as you exhale, it automatically relaxes so that what it allows the body to do, since it doesn't stay on permanently like a neurostim does for your brain and for pain, is that as it fires on the inhalation, it stops firing on exhalation, allowing you to exhale normally, and over time providing homeostasis. So it's put in. Quick in the neck is where the electrode goes for the cuff to grab the hypoglossal nerve. See, it's your C12. Stick your tongue out. That's your hypoglossal. Okay, so what we're looking to do is to isolate part of the hypoglossal we use neurostim in the tongue so that we can test what are the parts of the nerve we want, what are the parts of the nerve we don't. I put this picture in because it shows that our surgery has improved and changed over time. Originally, it was a 3-incision surgery, neck, chest for the generator, and between the 5th and 6th ribs, we put the respiratory sense lead. This was probably the most uncomfortable of all the incisions. We got rid of it when we put the respiratory sensor up above now, and there's only one tunnel for the terminal wires. And this is the cuff in situ. So you can see where we've isolated the top part of the nerve on the left out, because that's part of the styloglossus and the hyoglossus, which pulls your tongue back. We don't want that. And the genioglossus and the geniohyoid pulls forward, including the C1, which is really great because when this thing fires, they get a free hyoid suspension. That's kind of one of the perks. We give you a free hyoid suspension. This is the cuff. It's self-retaining. It's silicone, no allergy issues with any of the materials. And then we have a little barrel here that we tie down on the digastric, and that gives us a strain relief so that the patient can use their neck and do everything that they're supposed to do. Okay? Here's a picture of the new surgery now. It shows the 2-incision technique, much easier. It's cut surgery down time-wise by almost 45 minutes for some people. It's much faster, and it just pops right in. The respiratory sense lead goes between the second and third rib, facing axially, away from the chest because we don't want to get any cardiac noise if we can avoid it. And the beauty of this is that we have come to find out, and having dealt with sleep and breathing patients for 40 some odd years, most sleep apnea patients are super shallow chest breathers. They're very shallow breathers. So the respiratory sense lead waveforms that we get, since we're putting it up higher, are better. They're more robust because these people are only filling the top third of their lungs. And just food for thought. Just remember, people with sleep apnea who got COVID and they vented them, the ones who died, they proned them trying to fill the back of their lungs, right? That's what they did originally. They proned you, they put you on a vent in the hopes of filling the back of your lungs to help you breathe. Those alveoli hadn't had any oxygen in them forever. So what did we do? We blew air in on the vents and then caused microbleeds, causing systemic failure. So it's good to know. If you only use the top third of your lungs, all of a sudden, filling the whole lungs is not going to be a good idea. This is what it looks like. We take x-rays of both the neck and the chest afterwards. We do that in the PACU. That's so that we always know where it was when we started. This is a size quarter, the generator. I put this up here. It originally came out of Medtronic back in the day. It was something, and Medtronic was like, oh, you guys take it. We're not going to develop it. And the size of the generator this is half the size of the original ones. And it runs on, the patient's remote is nothing more than a glorified garage door opener. Now, the frequencies that these operate at are not the same as a garage door opener, so your neighbor cannot turn on your device, which is important. And these are lovely patients who have graciously allowed me to film their tongue motion. Now, why does it pull out what looks like to the right? It's actually the patient's left. It's because since we only cuff the one side, it's going to push towards the left. And it's a gentle motion. Notice the tongue is not going to Cleveland. It's just going out just beyond the lower mandibular sextant. So if they're using it in combination with their oral appliance therapy, as long as their tongue can move freely in the front, we're good to go. Okay? And this is when it looks more like the tongue raises and moves forward. So we want a stiffened, flattened tongue. But this patient, the reason that I'm showing you this is because she had a really bad tongue tie. And her tongue motion changed remarkably after we released the tongue tie. And I was able to take her stimulation down by a half a volt. That's a lot. Because her tongue was untethered and it could move forward. It's just kind of unusual. How do we test this? Over a number of months, patients take a while to acclimate to this. During the STAR trials, 30 days after you got this thing turned on, they did a sleep study. We don't do that anymore. We don't tell people to turn it up every 3-4 nights. I tell them, you're turning it on tonight for the first time, you don't touch this for 2 weeks. Don't touch anything. And then once a week, I want you to go up the ladder, because you don't start at therapeutic. You start below therapeutic so that they can adjust to it, acclimate to it, have their brain adjust to it, psychologically adjust to turning this thing on every night, having this be part of their life experience. So we put it when we finally do get a sleep study, though. This is what it looks like. They start the night without it on, and then when there's delay, the remote control, we turn it on, they have a delay. It's set to the patient's sleep cycles. So there's a delay. The patient is in N2 sleep when it goes on. It's on. They can pause it if they need to get up to go to the restroom. And then it goes on by itself in 15, 20 minutes or half an hour, whatever they need. And then they turn it off in the morning. So they are controlling, and then what level they're at. So we started at level 3 maybe. We give them a couple of steps they could go backwards because people like to be heroes in the doctor's office, and then they get home, they're like, ugh, too strong. So we want to give them the idea, and psychologically, knowing you can choose to go backwards is very important. Very important. So you go back, I don't care. Send us a note, let us know. 3 weeks, send me another note, tell me where you are. If you're struggling, I'll get you back in, we'll figure this out. And if you're doing fine, just keep going. Sleep study shows everything smooths out and is 96 to 97% oxygen saturation all night long. Obviously it works. Pathway is that, again, screening, the examination, airway examination, we activate it. Well, they have surgery, then we activate it. Then they go in for their sleep study and long-term longitudinal care. This is kind of where I come in for the ones that don't do well. So this is called Inspire Cloud. Pretty cool, because what it does is it allows us to look at how they use their device. It doesn't give me an AHI like your CPAP machine does, but what it does is it allows me to tease out behavior. So on the bottom here on the left, because I needed to get them all on one screen here, the dark green is the delay. That means this patient is turning this on and off every time you see a green block, on and off. And the light green is when the therapy is actually on. So there's problems here, skipped a few nights, and there's problems here with the fact that it's turning on and off a number of times at night. Okay, I took one look at this, and this tells me a couple of things. They basically go to bed at the same time every night. A night owl, so somebody who stays up till 1 o'clock, 2 o'clock in the morning. Okay, retired, you can do that. You're allowed to do that when you don't work anymore. And so, but STIM's waking them up. All right, STIM's up too high. Took the STIM down 3 steps. And then set an alarm on his phone. Okay, so you go to bed, you fall asleep around 2 o'clock, okay? But some of these nights, well, I forget. Okay, alarm goes off at 1:30. Brush your teeth, floss your teeth, have a drink of water, go to the bathroom, let the dog out. Go to bed. You've already turned it on. Done. We set your delay so that you can do all of those things and that it won't turn on until you're asleep. So that way it reminds them every night to turn it on. It's a simple thing. And after a couple of months, they don't need it anymore. Okay? Improved adherence up on the top. Improved adherence, okay? Much better. Still some pausing, doing that. And I noticed that, gee, the pausing is Saturday and Sundays or the night on a night where you don't have to work the next day sometimes. It was just a conversation. I'm like, so how much you drinking those nights? Curious. I don't care. I don't judge. Just curious. Because this isn't helping you. So just a quick question about, now, a lot of you guys used HRPO for looking at your patients who've got their oral appliances. I love high-res pulse ox. Love it. I also like cardiopulmonary coupling a lot. I beta tested WatchPat back in the 90s. I've beta tested CPC back with David Baker before it even belonged to these people that have it now. And I've used HRPO for my patients for years. Doesn't give me an HI, not a true one, but what it does do is it allows me to pick up behavior. So why do I give out an HRPO on a Thursday night? You got to go work Friday, right? So you're basically going to behave, right? But Friday night, you got it Thursday, Friday, Saturday, Sunday, I want you to run it. Doesn't cost you anything, just do it, please. Thursday night looks like a pretty good study. Friday night, we had a couple of beers when we went bowling with the boys. Saturday, they went to a wedding, kind of tied one on at the wedding, and then had a couple of hits off the bong in the evening. So, and then Sunday night was like Thursday. Okay, bookends. So what does that tell me? I lay out all 4 days, and the guy's 10-point difference in estimated apnea. 12-point difference. I'm like, so what went on Friday and Saturday? And I said, I don't care what you did really, but I want you to see how your choices affect your sleep. You choose this. It's up to you. I'm not here to be your mother. although half the time I am. But you know what I'm saying, is that I'm not here to help you. I'm here to help you see that the choices you make adversely affect your ability to sleep well with your therapy. And that goes for Inspire, and it goes for oral appliances, and it goes for CPAP as well. So, big game changer, July 6th of this year. Hypoglossal nerve became full body MRI approved. So, at one point, if you needed MRIs of anything but your arms, neck, your head and neck, arms and legs, you couldn't get it because you'd have to take the device out to get the MRI. Well, it's full body approved for MRI, which is huge. That's really big. So now as long as there's a Tesla 1.5 machine somewhere in the locale, you need an MRI of your back or your stomach or something, not a problem. This is a huge game changer, and the phone lines have gone rung off the hook ever since for people who couldn't get it and because of the MRI issue. Patient satisfaction is enormous, very high. People who get it, 92% say they'd do it again in a heartbeat. They use it, they like it. The quality and life compliance reports, all of the stuff is available online, and it's all through the FDA. So there's no bias, okay? The OSA burden reduction, longitudinally, because these are patients we've tested at 6 months and again at 12, it still stays under 10. And that's using the AASM 3% rule. So that's huge. It would be even better using the AASM 4% rule. Because remember, AASM 3% rule, AHI of 20 is an AASM 4% rule, AHI of 3. Big difference, okay? And always got to talk about it is surgery. Has complications. Do we take these things out? Yes. Do we revise these things? Yes. How often? 0.001% of the time. And since 2018, the reason for taking these things out, or the numbers of them, has dropped drastically as surgery has changed. As we've improved, everything's improved. And my red line belongs across MRI compatibility because that is no longer an issue. No need to take it out because you need an MRI of your back. So, is this standalone therapy? You bet. For a lot of folks, this works great all by itself. They get rid of their CPAP, or anything that they do. Let's say they couldn't or wouldn't wear their oral appliance longitudinally, day in and day out. Average nightly use for this is well over 6 hours, which is every night. It's 7 days a week, every night, for on average 6-7 hours a night, which is huge. Is it good by itself? Yes. Is it better for patients who struggle in combination with other adjunctive therapies? And I would hazard to say yes. We need to understand patients' history, their culture, whether or not they're comfortable. Not easy to watch somebody's tongue protrusion through a hijab, but I've done it. Not easy to do. Not easy to do with somebody you have to do surgery here and you can't shave their neck. Okay, I've done that too. You have to understand that there are cultural situations that you have to factor in, but sleep apnea is global. It's not just anywhere. Do we need to understand cognitive behavioral therapy? I think for any and everything we do for all of our patients, even oral appliance patients, cognitive behavioral therapy to get rid of the insomnia, to get rid of rumination, to get rid of some of the issues surrounding their sleep fragmentation is a win-win for everybody, and they are not crazy. They have sleep cycle disorders. Okay, well,